Okay, thank you for having me. We'll discuss a difficult IVC filter case today. I have no disclosures. The patient is a 39-year-old male who's admitted on transfer from an outside hospital for painful lower extremity edema, left greater than right. His past medical history is significant for recurrent pulmonary emboli and deep venous thrombi. He had an IVC filter placed at an outside hospital about 6 months prior to this presentation, is prescribed on Pradaxa right now, and has an ongoing habit of illicit drug abuse. So at the outside hospital, they did CT venogram because of the extent of the symptoms and the physical exam. On the right side, they found an IVC filter that looked well positioned, no sign of a thrombus in the area. The venous system inferior to the IVC filter on the right looked patent as well. However, on the left side, they found a left IVC that was congenitally persistent. There's an IVC filter also in that left IVC, and there's a degree of thrombus associated with that IVC filter on the left side. The anatomy is such that the left-sided IVC drains into the left renal vein. The left renal vein drains into the right IVC. That left renal vein is patent with no sign of thrombus. However, inferior to the left-sided IVC, there's substantial thrombus all the way down, extending down to the popliteal vein below the level of the left knee. They comment that it's not occlusive on that imaging, but we'll see how it is later. So our plan for the procedure at our institution is a three-pronged approach. First is thrombolysis of the left-sided system, given the extent of disease. Second is ballooning and stenting. And then third is IVC filter removal. Both sides is our plan at the time. So the first procedure, we access the left popliteal vein, ultrasound guidance, and I'll remind y'all for the first two procedures, venograms, the patient is prone, so his left side is the left side of the screen as well. We do venography, thrombolysis with angiojet and ECOS, have to balloon through the struts of the left-sided IVC. So we'll look at the venograms here. This is first a scout image showing the IVC filters on both sides. And again, the left side of our screen right now is the patient's left side as well. We get access, do a contrast injection, which shows extensive collateralization and obstruction right there below the level of the femoral head. We pass an Amplatz wire up through the IVC filter on the left side and pass the angiojet all the way up from the popliteal, the popliteal vein up to the level of the IVC filter, come back down, have 30 minutes of letting TPA infuse, do a balloon angioplasty through the struts of the IVC filter, do contrast injection again after passage of the angiojet thrombolysis system. So shows improvement, but still not optimal. So after this, we place an ECOS catheter and have the patient in the CC overnight with continuous infusion of TPA and heparin. Bring him back to the cath lab the next morning, use the same sheath as our access, and do ballooning and stenting of this area in which we're interested. So this is first a reverse bolus chase. This is immediately after the ECOS catheter is removed. Contrast injection showing a good amount of improvement, especially in the collaterals. The true lumen is still not completely patent, but significant improvement after thrombolysis. This is a still of our ballooning all the way up and down the area of interest. Contrast injection again after ballooning shows final definition of the original true lumen with still some stenosis along the way. We did not think that this was going to be adequate by itself, so we decided to stent all the way through this area. This is an image of an ICAST covered stent, and then a second one overlapping in the mid part. Then we did a open cell stent, superior and inferior margins of this area of interest with post-dilation. Balloon is still right here, which will show final contrast injection after ballooning, stenting, and post-dilation ballooning, which shows some thrombus right there, but then following the true lumen up, much improved from what it was before. So we're hopeful that at this point that we can bring him back for the final step of the procedure, try to remove both IVC filters through the right internal jugular vein. We first approach with the patient supine, so his left side is now again on the right side of the screen, a glide wire down to the level of the left IVC filter, which you can see that the level of the stent superior aspect of where we were working before is right there. We advance a glide catheter over a glide wire down to the level of the left-sided IVC filter, but we come to this obstruction where you can see that the tip of the catheter is impinged there. We advance a 12 French Denali retrieval system and shoot an angiogram which shows complete obstruction superior to the left-sided IVC filter. It looks like there's even maybe some calcification there. So we try to advance a 018 system with ballooning through the struts. You can take my word for it, after more than an hour of trying to get this thing out, we couldn't do it. So we go to turn our attention to the right-sided filter, and in the interest of time, I'll skip that first video that it was an unsuccessful attempt to retract it, but we succeeded on the right side. So we're able to get that one out, but the left-sided IVC filter is still in there. So we send the patient back to the telemetry floor. We consulted hematology, who recommended a heparin drip acutely. Surgery was consulted to see whether they would perform an operation to remove the IVC filter. They said no appropriately. And while we were scratching our head trying to come up with a plan, the patient leaves against the medical advice because he was dissatisfied with his pain regimen. So thank you very much for your time.
It's a very interesting case. I can't say that I've ever seen a left-sided IVC filter with two at the same time.
Yeah, I mean, I think it underscores the fact that you don't put in IVC filters,
Right.
number one. Number two, you definitely don't put them in left IVCs. Number three, you don't put them in somebody who's going to be non-compliant. I'm a little surprised that who did that. I haven't seen a left IVC filter in a long time. Have you come across any? Mm-hmm. Was that a wall stent, or was that a smart stent that you dropped in there on the femoral vein?
Wall stent.
Wall stent, okay.
It appeared to me that the left-sided IVC filter was significantly compressed.
Yes, sir.
It really stretched out. Do you think the left IVC was significantly smaller diameter?
It was. They commented on that CT venography report that the native vessel was significantly smaller in diameter than the right-sided, but we had the impression that the two filters looked about the same size. So when they implanted it originally on the left side, they way oversized it in our opinion. So that's another reason why we think it was so obstructed there.
Mm-hmm. Was there some concern about the longevity of all that work that you did in the presence of that IVC filter clotted in place there? I mean,
yes, there was. And we were kind of grasping at straws at this point. This had been a referral out, and my attending knew the physician at the outside hospital who was managing him from before. In retrospect, it probably would have been best for us to be as minimalist as possible in his case, probably just the thrombolysis, to be honest, and then the IVC filter removal. In the moment, we thought that it was best for him, but before we knew how difficult he was on the social side of things. But it probably would have been best to not have put those stents in there.
Just to comment, as somebody who does these kind of procedures, unlike arterial cases, venous cases, you really don't care how pretty the images look. So we do stent IVC sometimes. I've never used a covered stent. We usually use just the wall stents. But we found out that there's a device called the cleaner device, which kind of is a helical device that rotates and pretty much messes up your clot. We do this, we clean up the IVC and whatever veins you want before you put the ECOS catheter. That helps resolve most of the clot. And something you can do with this filter, instead of removing it surgically, which most surgeons would say no to, actually not stent anything below it and just stent the filter itself. So if you stent across the filter will stay there because you cannot remove it anyway, but that will open a passage. Because now all the stents that you put in, just because there's no outflow, they're going to thrombose, versus you keep not a very nice looking veins, but you stent that IVC to open it at the filter side, it will empty, it will clean with time event coagulation.
This is actually where you could use an atrium stent. You could crush it with a covered stent, and would be a very good use for it, and just blow the hell out of the thing.
Absolutely.
The first device you were describing, it's just mechanical thrombolysis. It's not a chemical as well.
It's not it's mechanical. It's not. Fragmentation fragments very, very well. You have to use it when you have a filter. So It's actually great that the filter is obstructing the flow. This way, nothing will accumulate, but it fragments the clot so much that when you put the ECOS catheter, you need less TPA, less time, and it cleans up pretty much very nicely. And then you don't stent anything; you just stent that filter.
You didn't have a picture of the ECOS. Where did you have the tip of the ECOS catheter? When
It
you
was
put
just superior to the filter, and it was 135 centimeters in length. So it got below the femoral head, about the femoral vein, but not quite down to where we wanted it to, but just superior to the IVC filter.
What was your dose total of TPA that you get?
It was 10 milligrams total.
Okay. Okay.
Thank you.
Thank you.
Thanks.
See you.